We already talked about how long immunotherapy should be given for. Naiyer, any reason to assume this would be different second line than it was in the first line?
No, I mean, I think the sort of treatment paradigm is the same. Yeah.
And what about the combination then of chemotherapy and a PD-1 inhibitor such as pembrolizumab or Nivo? First line, we've seen promising data. Is there any similar information in the second line setting, say combining it with a taxane?
So the key question, Everett, here is if a patient already got immunotherapy in the first line and they progressed and you're switching to a platinum doublet, should you continue the immunotherapy forwards along with the chemo, or should you just do a clean cut and move in a different direction? We don't know the answer to that question, but the good news is ECOG, ACRIN, and SWOG investigators, some of Dr. Herbst's, Roy's colleagues are working on this trial to understand that question specifically in a randomized clinical trial. So we need to start thinking in that direction. At this point, though, I would say there are some promising approaches combining chemo with checkpoint inhibition. We saw one trial at this meeting of combining nab-paclitaxel with durvalumab, which seemed to have PFS in the order of about 4.5 to 5 months. Things that I think will have to be tested further in larger cohorts and randomized settings. I know that the lung map study that Roy is spearheading with SWOG and other groups is very interested in developing combination approaches in the second line setting with immunotherapy based approaches. I think that's going to provide us with new insights into what are the combinations that will be effective for patients.
We have in the Alliance a trial that just started that is a little bit based on this kind of thinking, where nivolumab is given as the standard and then the experimental arm is nivolumab plus nab-paclitaxel. So looking at the interaction of PD-1 inhibitor, a little bit similar to what Keynote 21G did first line. In that context, Roy, the lung map is really the national trial for second-line therapies. It had originally been squamous cell only, but you're in the process of changing and broadening this, right? And
right, so the feeling was why drivers are only important in squamous cell, and also it turned out that most of the drugs or combinations that were being studied turned out to be immunotherapy combinations. So the new version of LungMap, which is just about to launch, will actually have all tumor types allowed, and we're looking still at driver targets and armed antibodies against driver targets. And actually Fred's very involved with the translational aspects of this. But then we also have to look at immune combos, and the idea would be to look at IO-IO combos. Now the good news is we're going to have a large funnel to look at a large number of patients. All patients are going to have biopsies, so we'll be able to look and correlate activity with the biopsies. The hardest part of this is finding those combos that have had enough phase 1 data, that have either preclinical data or data of activity in lung or other tumor types to move forward. But that's been our challenge, and we're actually very excited about a couple of combinations, mostly combinations that are looking at a PD-1 agent plus an agent that might inflame the microenvironment, like an interleukin of some sort, anti-angiogenesis inhibition in combination with immune therapy. So we're very actively working, and actually the nice thing about LungMap, as you know, is all the groups are working together. Yeah. So you and I
and getting along.
And the beauty with this infrastructure is that we can actually adapt to the rapid progression in the field. We have since we started LungMap, we have been able to modify the LungMap structure and the designs accordingly to what has happened in the field, and that has been quite an encouraging.
So Roy, I just want to follow up a little bit on this. So you mentioned IO-IO combinations, but why not test IO-chemo combinations second line?
That's a good thought, and that's being looked at. And I always thought when I saw the Keynote 21 data, and actually working with Mario Snow, we wrote an editorial on that might be the place to use these agents. Because in the front line, we have a group that's high that can get these drugs alone. But it might be that in the second line, that might exactly be where to use it in patients that are PD-L1 low or totally absent, and to use chemo plus. And I think that certainly could be an approach. We're going to have a common control in the lung map, which will probably be some sort of chemotherapy. So what better than to take an agent chemotherapy versus chemotherapy alone?
Yeah, wouldn't it also allow us to look a little bit at this, scientific evolution then of PD-1 inhibition, PD-L1 expression in cohorts getting chemo as opposed to those not getting chemotherapy, and seeing how dynamic that biomarker really is.
Yeah, I agree. That's certainly something to think about, and there are many patients who are going to be, as Ram said, in the second line. Do we keep the drug going or not? I think those are very reasonable approaches as well.